Okay, Chapter 8 is on emergency care. What you need to know for this chapter is if there is an emergency, you need to know the patient's care plan, and you need to know if they are a DNR or do not resuscitate, and you need to get the nurse immediately. So have the person stop what they're doing, sit down, rest, and call for help. You are going to learn American Heart Association First Aid and CPR for things that you can do in emergent situations. There's some videos in those courses that show you what you can do as a good Samaritan or out in public. But if you are working in a facility, you have to follow facility policies and do what emergency procedures you're trained and able to do. But basically, have the person sit, lay down, rest, get their vital signs, hold direct pressure if they're bleeding, and get the nurse immediately for help. You are not allowed to give medications. You are not allowed to do extra, like put in trachs or put in IVs or put in Foley catheters for these patients. So just the basics with your roles and responsibilities in an emergency. Use standard precautions. Put your gloves on, put on some PPE. Always make sure you're remaining calm. Let the resident know that you are there to help, that you are trained in first aid, and that you will help them with their situation until help arrives. Don't move the resident unless you're moving them from a dangerous situation. We talked about falls. If you have a falling resident, do not get them off the floor by yourself because they may have broken a hip or fractured a bone. Moving a resident improperly could cause further injury, especially if they have injury to their spine or their pelvis. So make sure that you know where your emergency equipment is kept. We talked about the code cart already. Attending emergency in-services, it is your responsibility to keep your first aid and CPR card renewed and up to date every 2 years. Always answer your call-outs immediately because patients are more worried about their physical needs than their safety. If they press the call bell, they need to go to the bathroom, they wait for 5 minutes and nobody comes, they're going to get up and go to the bathroom or attempt to get to the bathroom by themselves. They're going to slip and fall and injure themselves. You can keep that injured person warm by covering them with a blanket, giving them a pillow, elevating their legs if you can, call the charge nurse, and then you may be asked to call 911. So you need to know the address of the building that you are working at. You just can't tell them the name. You have to be able to give them the physical location or physical address of where you are so that emergency services can respond. So we're going to go over some common medical emergencies, just the basics with what you need to know about them. A heart attack is a myocardial infarction or an MI. It is different than a cardiac arrest. A heart attack is when the blood supply to the heart or coronary arteries is interrupted. There's a clot that is blocking off the blood supply to the heart, usually due to plaque buildup in the arteries that is broken loose, or blood clots from AFib, or some kind of clot from a DVT in your leg. Your symptoms are going to be your chest pain, spreading to the shoulder, the neck, the arms. Women sometimes complain of indigestion, difficulty breathing, shortness of breath, palpitations. They say they can feel their heart fluttering in their chest. So anytime someone complains about any kind of chest discomfort, again, it's angina, however you want to pronounce it, or they say, I'm having chest pain, you have to let the nurse know immediately. Sometimes they just have nausea and increased anxiety, stomach pain, indigestion, weakness, fatigue. They feel cold, they feel pale, they get clammy, their heart is beating at a rapid, irregular pulse. Let someone know, have them stop what they're doing and sit down. So notify the nurse immediately, have the resident stop all activities immediately, have the resident sit or lay down if possible, take their vital signs. Sometimes the vital sign machine is not going to work. If their heart is very irregular, you're going to have to do it manually. But that's why we learn how to do manual blood pressures. Feel their pulse. It may be weak and faint and rapid. The machine may not pick it up, so you need to know how to do a manual pulse. Stay calm because the resident is probably frightened. You can loosen any tight clothing for them. Sometimes they get hot, diaphoretic, and sweaty. The next heart problem is a cardiac arrest. This is when the heart stops beating. This is an electrical problem with the heart. This is when we're going to start CPR. Again, you're going to learn how to do the steps of CPR. If you just want to do compression-only CPR, make sure you're pushing hard, you're pushing fast, you're pushing at a beat of 100 to 120 beats per minute in the center lower half of their breastbone. Okay? When they're having the cardiac arrest, the circulation has stopped, so you need to circulate the blood for them manually. by doing deep, at least 2 inches chest compressions. But again, make sure they are not a DNR. So if they are a do not resuscitate, you don't want to start CPR on them. Symptoms include no pulse. You're not going to be able to have a respiration. They're going to be unconscious on the floor. They're cool, they're pale, their lips are blue. They are loss of consciousness. What to do? Get your nurse immediately. Stay current with your CPR. The next medical emergency has to do with your brain. Strokes. So a lot of patients have strokes because of uncontrolled blood pressure. We talked about hypertension being a blood pressure above 140/90. So make sure you know what your blood pressure is and you're keeping your blood pressure under control. But strokes are when clots break off and go into vessels in your brain, or they happen when brains hemorrhage and rupture and you bleed out inside your skull. So a stroke is a CVA, or a mini stroke is a TIA. CVA stands for cerebral vascular accident. TIA stands for transient ischemic attack. It means that it's transient, it just happens over a brief period, but it resolves itself and goes away. Brain cells are going to die without oxygen. So whenever you have a blood clot in your arteries, in your brain, or your brain has ruptured, those cells are dying and they do not come back. Symptoms are going to include, we talked about the acronym FACE. So F for your face drooping, loss of face, hand, arm, leg, or body control. It's usually just on one side of the body. We talked about face for F for face, face drooping. The A in FAST is arms. If they hold their arms out in front of them and one arm is drifting downwards and they can't keep their arms straight because one side is paralyzed and the other isn't, or one side is losing the ability to keep it elevated, or muscle control. Difficulty swallowing, and the S in FAST stands for speech. We want to ask them to say something to you. And if they say something that's slurred, or they're not saying the correct words, or they have aphasia, where they're having difficulty putting thoughts into words or difficulty speaking at all, that is something that you need to report immediately. Difficulty swallowing, if they're choking on their food. And sometimes people just have a change in their sight or their thought process. They're not saying the words that they think that they are saying. Or they tell you that they can't see out of one eye. Or they have impaired memory. They have a severe headache. Usually they say it's the worst headache that they've ever had in their life. So this again was your acronym for your FAST. I'm trying to get it in place there. But your FAST is the acronym that you do in case of a stroke. Act fast, and the T in FAST means time to call 911. The sooner you get that person to the emergency room, the sooner we can get the medications to get rid of the clot, or we can take them to surgery to stop the bleeding. What to do? Get the nurse immediately. Have the resident stop all activities immediately. Have the resident sit or lie down if possible. Take their vital signs. Stay calm. They're frightened. Loosen any tight clothing. It's always the same steps that you're going to do in a medical emergency. And the biggest thing is for you to remain calm, let the resident know that you're there to help, and that you are trained and you are capable of helping them until more help arrives. Choking. We already did the Heimlich maneuver, but choking is when an object is blocking the airway. So on your checkoff sheet, it says FOAB, foreign object airway obstruction. Okay, so symptoms of there's something in their throat. They're going to be clutching at their throat, their hands usually. They're not going to be able to breathe. They're not going to be able to talk. They're not going to be able to cough. They're going to start turning blue. If a resident is coughing, you're just going to help them, encourage them to cough, pat them on the back, do a few back slaps, but don't give them any water, because if you give them water, it may go down and they will aspirate on the water as well. You want them to cough it out, to get it out of their airway and into their esophagus, or cough it out and get it out back onto the plate. So if they are truly choking, you are going to get at waist level, pull your arms around their stomach or their abdomen right above their umbilical, in their belly button, and press in and up with jolts or abdominal thrusts. You do the abdominal thrusts until the object comes out or the patient passes out. Once the patient passes out, you're going to have to start CPR. Okay. The only difference in after you start CPR on a choking patient is that every time you've done with your 30 compressions, you're going to check for the airway to see if you see the obstruction and try to get the obstruction out with a finger sweep before you try to give breath. What to do if you have someone that's choking. Call the nurse immediately. Determine if they're breathing. Look for their chest to rise and fall. Listen for their escape of air. Feel for the flow of air. You don't spend too long doing this. If they're not making sounds, they're choking. They have a foreign airway, a foreign object airway obstruction, so they need to have the Heimlich maneuver. Make sure your hands are positioned above the navel, well below the sternum or the breast of the tip, the breastbone, or the xiphoid process. You don't want to break that xiphoid process off and puncture their lungs. Give your thrusts until the object is expelled or the person becomes unresponsive, and then you're going to use the head tilt chin lift method to open their airway and look for the obstructing object. You're not going to do a blind finger sweep. You have to see the object before you can stick your finger in the cheek and hook it around from behind and pull it out. So this is your video again on the Heimlich maneuver.
An obstructed airway occurs when the victim's airway is partially or completely blocked by a foreign object. This commonly occurs while eating. The universal sign for choking is one or both hands over the throat. If you notice a resident who appears to be choking, ask if he or she can speak. Stay with the resident, call out for help, or use the call signal to summon assistance. Tell the resident you will help. Stand behind the resident. Wrap your arms around the waist. Do not let your forearms rest on the lower rib cage. Position your hands at the resident's midline, just above the navel and well below the xiphoid process. The xiphoid process may be found at the lower tip of the sternum or breastbone. Make a fist with one hand. Position the thumb next to the abdomen. Grasp your fist with the other hand. Press your fist into the abdomen using quick inward and upward thrusts. Deliver each thrust with the intent of freeing the obstruction. Repeat the abdominal thrusts until the foreign body is expelled or the resident loses consciousness. Each new thrust is a separate, distinct movement. Be careful to avoid pressing on the ribs. Continue the procedure until the nurse provides further directions or the resident loses consciousness.
All right, so we practiced the Heimlich maneuver on each other. Just make sure you know how to do that. If your resident is sitting in the chair, you're still going to get behind them, and they don't have to be standing up, but get behind them and do your abdominal thrusts to try to get it out. The next is a seizure patient. This again is with the brain. It's an electrical current problem with the brain where they start having seizures or convulsions. People with seizure histories usually have seizures. Even if we have given them medications, they still may have a seizure, a breakthrough seizure. Sometimes they have grand mal seizures where they're twitching their entire body. Sometimes it's just one particular arm or leg or hand. If it's a rhythmic motion, then it is likely a seizure. People also have silent seizures where they just lose consciousness and stare off into space. If they're shaking, twitching, you can't get their attention, look at your watch, see what time it is, and time how long the seizure is going on. The important thing for us to know is how long the seizure lasted and what body parts were affected. Let the nurse know. They may lose consciousness. They have a loss of all of their muscles. They have massive muscle spasms. They're going to be incontinent of their urine and their stool. They may fall to the ground. Turn them on their side so they don't vomit and aspirate on themselves. And also do not put anything in their mouth. We were putting things in their mouth, we were knocking out their teeth, and then they were aspirating on their teeth. So it's a myth that they're going to swallow their own tongue. They may bite their tongue, But if they do, we'll stop the bleeding after the seizure has stopped. But don't put anything in their mouth while they're actively having a seizure. Okay. What to do? Call for help, move any objects out of the resident's way, loosen their clothing, turn their head to one side to prevent aspirating their vomitus. Do not try to hold the patient down or put anything in their mouth. Note the length of time of the seizure and the body parts involved. That's what we need to know. Okay. For burns, we have to use our RACE acronym. Make sure we're removing the resident or rescuing the resident that's in any immediate danger from the burn. And now if they are actively on fire, they need to stop, drop, and roll, or you need to smother them with a blanket or throw something on top of them to get the fire to smother. Don't run with you being actively on fire because that just gives it more oxygen. The rest of RACE is rescue, alarm, contain, extinguish, or evacuate. So call for help or alarm someone. And there it says again to stop, drop, and roll. Or get a fire extinguisher and use the pass technique. Pull, aim, squeeze, and sweep at the base of your fire. Okay. Small burns, we can rinse them under cool tap water for 15 to 20 minutes. Leave them under the water for a while. It needs to be on there. The water needs to run to help cool the area to get the heat out of it. There are myths that tell people to put butter on it and lotions. If you put any kind of oil or protectant on it, it's going to make the heat trap in the skin and go deeper and cause the burn to be worse. So run it under the cool tap water for 15 to 20 minutes to help pull the heat out of it, and then leave it uncovered. If it's not blistered, they probably don't need to go into the emergency room, but if it's over a good portion of the body or an arm or a leg or a face, then go on into the emergency room because they can definitely get infected. But don't put any petroleums or ointments on it while it's actively bleeding. There are different levels of burns. If they have a second-degree burn where it's blistering up and it's peeling off skin and oozing out goo, you probably need to go into the emergency room to have it looked at to make sure it doesn't get infected. Hemorrhaging is excessive bleeding. People can have internal bleeding because of medications they take. If they're taking too much warfarin or Coumadin, they can be bleeding internally from a gastric ulcer or a ruptured spleen or a ruptured liver, and we never even know. Their abdomen starts to hurt sometimes, and you can probably see some purple blue spots coming up and some distension, but usually unless they've had an injury that we know of, we don't look for internal bleeding. But people could be bleeding internally and they go into shock because of blood loss or fluid loss. For that, we need to make sure we're calling for help, remaining calm, keeping them warm with a blanket, elevating their legs. They're going to have hypotension when they go into shock. They're going to lose their blood pressure. It's going to go very low. So we need to keep them in a bed and elevate their legs to try to bring up their blood pressure. This is internal bleeding. They could also have an injury from a car accident, or they fell from a height, or fell off a ladder, or had something fall on top of them, or get hurt from a seatbelt. So external bleeding is bleeding that you can see. You need to call for help, but don't leave your patient. If possible, use your standard precautions. Put on some gloves, put on some PPE, or use a clean cloth and cover the bleeding and apply direct pressure over the area that's bleeding. Use the palm of your hand with some PPE and make sure you're holding direct pressure until the bleeding stops. If possible, you can elevate this wound above the level of their heart to let gravity help you so that the blood isn't flowing to it. But you're not supposed to use a tourniquet unless the bleeding just will not stop with localized pressure. And we'll learn about how to use a tourniquet in the first aid videos. Okay, again, if people are bleeding, they could go into shock because they have loss of fluid and loss of volume and they're bleeding out. So tissue organs not getting enough blood are going to go into shock. People in shock are going to have low blood pressure or hypotension. They're going to have a rapid, weak pulse. And then they're going to have rapid respirations or tachypnea as they're trying to catch their breath and breathe. Their skin is going to be cold, moist, and pale. They're going to look really diaphoretic and really sick, and they need to be laying down so that they don't pass out. Call for your nurse immediately, call for 911, elevate their legs if possible, don't move your resident, and then keep them warm with a blanket. So these are just some common medical emergencies that you need to know about, but the same theme in all of them is let the nurse know immediately. Stay with your resident. Keep them calm. Don't leave them alone. Have someone go get the nurse and take care of the resident, getting their vital signs, covering them with a blanket, giving them a pillow, holding direct pressure if you see external hemorrhaging.